pounding, throbbing, severe, disabling headaches. Migraines are the worst, but there are many proven treatments which we'll review today and the evidence behind them, and I have some timestamps if you want to skip ahead. Today we're going to review three aspects of migraine management. The first is lifestyle and alternative treatments. The second is acute treatments, what to do when you have a migraine, how to get rid of it. And the third, for people with frequent migraines, especially 2 days a week or more, or even chronic migraine, long-term preventative treatments known as prophylactics. By the way, my name is Brandon Beaber. I'm a neurologist. I also had assistance from a good colleague who is a migraine specialist who chooses to remain anonymous. People underestimate the importance of lifestyle in managing migraines in the long run. While you're taking some of these medications, consider making some lifestyle changes that may help you later, allowing you to get off or minimize medication intake. I recommend getting adequate sleep. Sometimes it helps to set a set bedtime. Stay well hydrated throughout the day. It's also beneficial to reduce the caffeine. Now, this is counterintuitive because during a migraine attack, the blood vessels in the head are dilated and sensitized to the pain, and in the short run, caffeine can actually help, and certain migraine medications like Excedrin contain caffeine, but too much caffeine intake is bad in the long run because you get a rebound effect and hypersensitivity of those blood vessels. Now, stress often worsens migraine. There's no way to avoid stress entirely, but you can manage it. I've had some patients have excellent reduction in migraine through exercise programs or mindfulness meditation. Now, some people with migraine have specific triggers. There isn't a single food that causes migraine, but some people note that they have more attacks when they eat chocolate or cheese, processed meats, red wine, caffeine, artificial sweeteners, sodium, or MSG. It may be helpful to keep a calendar of your migraines and record what you ate shortly before. If you notice a pattern, you may find a migraine trigger idiosyncratic to you that you can avoid in the future. Now, not everyone needs to take medication for every migraine. Some people are able to lie down in a dark, cool room and maybe try to go to sleep until it goes away, but in the modern world with work and other obligations and kids, that's not always the most practical approach. So here are some acute migraine treatments or abortives you can take to make a headache go away. The most common initial choice of medication would be over-the-counter medication, such as non-steroidal anti-inflammatory drugs. Some people take steroids, such as prednisone, temporarily. And we'll talk about some other prescription medications, such as the Triptans, dihydroergotamine, and newer medications called Gepants and Ditans. There are some alternative treatments, for example, massage and acupressure. This is a picture of an osteopathic practitioner doing suboccipital inhibition, which does seem to work for some people. Here are the most common over-the-counter medications used to treat migraines. I would suggest you talk to your own provider for personalized advice. Usually we recommend as a first-line treatment non-steroidal anti-inflammatory drugs such as ibuprofen, also known as Motrin. The typical dose is 600 to 800 milligrams, higher than the usual dose for pain of 200 milligrams. This can upset the stomach, and so you should take it with food. Naproxen, usually dosed at 500 milligrams, is a very similar medication. Aspirin and Tylenol are also effective, and the popular medication Excedrin is a combination of Tylenol, aspirin, and caffeine. It's fine to take this type of medication occasionally, but keep in mind that if you're taking caffeine later in the day, it can cause insomnia, which can in turn worsen migraine, so some people get in this vicious cycle taking too much Excedrin. The most commonly used class of prescription medications to abort a migraine are the Triptans. These medications target serotonin 1B and 1D receptors in the blood vessels and central nervous system, and they cause constriction of those dilated hypersensitive blood vessels. There can be some side effects with it. Some people can have chest discomfort, and it's thought these medications could be unsafe for people with risk factors for vascular disease, such as uncontrolled high blood pressure or history of heart attack and stroke, so talk to your own provider. These medications are usually given in pill form, though there are some alternative formulations. Typically, they are most effective if you take it right at the beginning of a migraine. Some people, they don't like to take medications. They wait to see how bad their headache is going to be. Unfortunately, that could make it less effective, so I advise taking it right away. You can take a second tablet 2 hours later, but you really shouldn't take more than 2 in 24 hours or 9 per month because of this effect of constricting the blood vessels. If you have more frequent migraines migraines than that, you should consider going on a long-term preventative or prophylactic therapy we'll discuss later. So sumatriptan was the first medication in this class developed, known as Imitrex. Usually for younger healthy people, I advise the highest dose, 100 milligrams, because it's the most effective. Zolmitriptan or Zomig is a very similar medication. Naratriptan or Amerge or Frovatriptan or Frovid are a little bit slower acting and maybe a little bit less effective, but good and well tolerated for people with slower onset migraines. And it's thought that the most effective medication is probably elatriptan or Relpax, but it can have the most side effects at the higher dose. There are also some problems where there are drug-drug interactions that are slightly different with these medications. So you have to check on your other medications. Now, for people with severe nausea, they may have difficulty swallowing pills during a migraine attack. With sumatriptan or Imitrex, there is a nasal spray or an injection, and the injection is actually a little bit more effective, as I'll show in a moment. There's also a dissolving tablet with rizatriptan or Maxalt and with zolmitriptan or Zomig. So those are some alternatives for people with severe nausea. This is a randomized controlled trial looking at elatriptan, which is Relpax, versus placebo, and we're looking at the percentage of people who improved after 1 hour, 2 hours, and 4 hours, and you can see you were much likely to improve if you got the Relpax, about 70% improved at 4 hours versus just around 30%. This is another study looking at different formulations of sumatriptan or Imitrex, so we're looking at the injectable formulation in the green line, the nasal formulation, the spray in the blue line, and tablets in the red line, and this is minutes after the dose and percentage of people who had a response, and you can clearly see that the injectable formulation is the most effective, followed by the nasal spray, and lastly the tablets. There's an older medication called dihydroergotamine or DHE. This isn't as commonly used these days because of the unfavorable side effect profile, but I've had great results with it for people with severe refractory migraines. So it can be given either intravenously or under the skin subcutaneously. Usually we start it off by giving the lower dose 0.5 milligrams and then escalate to the full dose of 1 milligram up to every 8 hours. It's a venoconstrictor, in other words, it constricts the veins, and it can cause some side effects like chest pain or muscle cramps, which can be quite severe. There's also a rare side effect of retroperitoneal fibrosis, which is basically developing fibrous tissue near the aorta, which can be very dangerous. You need an EKG and cardiac monitoring prior to starting it just because it can cause some heart conduction problems, but if it's well tolerated in the hospital, I have given it to people in the outpatient setting to inject themselves, and some of them have excellent results even though they've been refractory for many treatments. Again, this is not a first-line option. A newer class of medications to treat migraines is the gepants. These medications work on CGRP, which is calcitonin gene-related peptide, and these are neurotransmitters involved in pain sensory transmission. Now, it turns out if you give someone susceptible to migraine CGRP, it actually triggers a migraine attack, so blocking that neurotransmitter makes a lot of sense. Now, keep in mind that CGRP is throughout the body, so there are concerns that there could be other side effects similar to the triptans, and some providers have reservation in prescribing these medications to people with cardiovascular disease, such as people with a history of heart attack, stroke, or who have peripheral vascular disease, who are older, that kind of thing. That being said, they seem to have a relatively good safety profile. These drugs are also metabolized by a cytochrome system in the liver called CYP3A4. So if you give them while you're taking other drugs that are metabolized by the same system, either inducers or inhibitors, there can be a drug-drug interaction, so you have to check for that. These two drugs are Ubrelvy 100 milligrams and Nurtec 75 milligrams. This is a randomized controlled trial of Nurtec versus placebo for acute migraine. Here we're using a different endpoint, which is complete resolution of pain, which is very difficult to achieve. A lot of people with migraine, even if they get a lot better, they still have some pain, and so there's no drug that has great results for this endpoint. But you can see the triangle is Nurtec and the placebo is the star, and people taking Nurtec were much more likely to be pain-free at 2 hours, but you can see it was only a little over 20% that were completely pain-free, so not all of that effective. There really aren't a lot of head-to-head studies for these different drugs, and so people have attempted to do indirect comparisons known as a network meta-analysis. The problem with this is that different trials have different patient populations. For instance, people could have tried more migraine medications and failed in a certain trial, and they could sort of have worse, more refractory migraines, so it's not exactly that accurate, but it gives us a rough idea. So this looks at some different drugs and how they compare to placebo, and we're looking looking at the odds ratio, which is the relative probability that you will have pain relief at 2 hours. So placebo would be 1. This drug, elatriptan, seemed to be the most effective. This is Relpax 40 milligrams, the higher dose. You were 4 times more likely to have pain reduction at 2 hours. Sumatriptan or Imitrex, it was only an odds ratio of 3, so 3 times more likely than placebo to have pain relief at 2 hours. But for these medications, Nurtec, it was only a little over 2 for the odds ratio, so they weren't really that effective. These medications were highly hyped. People talked about them as really targeting the underlying pathophysiology of migraine, but if anything, they may actually be less effective than the older treatments. So in my opinion, they really should be used for people who fail other treatments first. The newest medication to treat migraine is this new medication, Lasmiditan or Reyvow. It's in a new class called the Triptans, and it agonizes or stimulates a different serotonin receptor than the Triptans. It's the 5-HT1F receptor, which is actually in neurons but not in blood vessels. Now, this is actually stimulated a little bit by the Triptans, but not very much. So the theory here is this drug could be safer and more well tolerated than the Triptans just because it doesn't have this effect of constricting blood vessels. Though it's relatively new, it's hard to comment on the safety. It can cause some side effects like sleepiness and dizziness, but is generally well tolerated. It's advised you don't take it with triptans or CGRP blockers, and it may cause birth defects possibly. There's fetal harm seen in animal data. But again, the results are not out of this world. Just because it's newer doesn't necessarily mean it's better. Now, this is a different network meta-analysis. You'll note the numbers are slightly different here because it's a different study. But you see, compared to placebo, the pain relief at 2 hours was about 3 times higher compared to 5.6 times higher for elatriptan or Relpax. So again, these medications should probably be used for people who don't respond to other medications. Now, for people who are having a lot of migraines that are severe and disabling, usually 2 days a week or more, or if you're just tired of taking so many medications, you may want to consider a long-term strategy with a preventative or prophylactic treatment. Now, of course, you should be doing the lifestyle things I discussed earlier, but here are some medical treatments you can use in the long run to prevent headaches. This is not for during a migraine attacks, but daily or regular treatments to try to prevent headaches. Now, we're going to start with conservative or alternative treatments, but a lot of the other classes of prophylactic medication in migraine are actually drugs originally developed to treat something else that were secondarily studied in migraine. This includes anticonvulsants or seizure medications, antidepressant medications, beta blockers that are usually used for heart disease or high blood pressure, similar with calcium channel blockers, the CGRP antagonists such as Nurtec, which I discussed as abortive treatments. There are different formulations used for long-term prophylaxis, and there's some random other treatments such as Botox injections and certain devices. In terms of conservative treatments, one of the most popular options is acupuncture, which definitely works for some people. There are also some nutritional supplements. One of my favorites is vitamin B2 or riboflavin. Now, you get some riboflavin in your diet naturally, but these are very high mega doses, 300 to 400 milligrams daily. It usually comes in 100 milligram tablets, so you take 3 or 4 tablets. You can take them all at once with or without food. The only side effect here is that it can make your urine a bright yellow color, but it's completely harmless. Another option is magnesium oxide, 400 milligrams 1 to 2 times daily, or the herb butterbur, which actually has class 1 evidence for efficacy in preventing migraines. You can see the butterbur flower here. Now, keep in mind that unlike abortive treatments, prophylactics in general take some time to work. I would recommend trying something for at least 4 weeks before deciding if it worked or not. These are some prescription migraine prophylactics. So these are anti-epileptic drugs or drugs originally developed for seizures. Now, both of these can cause birth defects, so I wouldn't recommend them to women who could become pregnant, particularly Depakote. Depakote can also cause some other side effects such as weight gain and elevated cholesterol. Topiramate or Topamax can be very effective, but it can cause some side effects such as tingling of the skin or rarely kidney stones. Some people taking it at higher doses think that it causes cognitive fogging, and some people call this medication Topamax, but a lot of people tolerate it quite well. Another option is the beta blockers. These are blood pressure medications. They can cause side effects such as slowing of the heart rate or lightheadedness. They're not well tolerated in people with asthma, and they could cause some interactions with other medications like other blood pressure medications. And the last category is the antidepressants, such as amitriptyline, which is Pamelor, nortriptyline is Pamelor, amitriptyline is Elevero, or venlafaxine. One medication I use a lot is nortriptyline. One of the benefits of this medication is that it's sedating, so a lot of people have migraine and insomnia, and the insomnia can sort of worsen their migraines, so it can help them with two things at once. Usually you start with the 10 milligram tablets, and you increase by 1 tablet per week up to 50 milligrams at night, or the least effective dose. It can cause some dry mouth as a side effect, and you're supposed to get an EKG prior to starting these medications for safety reasons, but they're generally well tolerated. This is a look at some of the randomized trials for these various medications, and you can see, looking at the standard mean difference for reduction in headache days, they do show an improvement, but maybe they reduce headaches by about half. So you shouldn't necessarily expect them to completely go away, but just reduce by a significant amount. And there's really no clear evidence that one is better than the others in terms of efficacy, so I usually recommend them based on what's likely to have the least side effects, or perhaps help someone incidentally with another medical condition they have. Like if they have high blood pressure plus migraines, maybe a beta blocker is a good option. We saw earlier that medications that block CGRP can help with acute migraine like Ubrelvy or Nurtec, but they can also be used long-term to prevent migraines. And so these are the CGRP blocker prophylactics. They're generally given under the skin at home once monthly. For example, Emgality, Aimovig, and Ajovy. And some of the medications, they start with a higher dose like Emgality and Aimovig, and then you give a lower dose monthly. And it comes with these auto-injectors, so it's really easy to use at home. They can cause the same side effects as Nurtec and Ubrelvy, and again, there's some possible concerns for people who are at higher risk for cardiovascular disease. There's also an infusion formulation, Vyepti, which is given in the infusion center by a medical professional through the IV once every 3 months, and the starting dose is 100 milligrams, but you can try going up to 300 milligrams if it's ineffective. Now, these are newer drugs, they're very well marketed, but they're not necessarily more effective than older drugs. For example, this is a randomized controlled trial for Vyepti versus placebo, and you're looking at the mean change in headache days per month, and of course, people getting Vyepti do improve, but the problem is people getting placebo also improve. Hey, people with migraines tend to go and get treatment when they're at their worst, so they may have a regression to the mean and get better spontaneously, or they may have some placebo effect. And really the difference here is only about 1 migraine per month, so not an enormous amount. So my thought is these are newer medications, potential safety concerns. I really only recommend them to people who don't do well on some of the older, more established treatments. Another option for migraine is Botox, botulinum toxin. Now this is a poison which weakens muscles. It's not exactly known how it helps, and it was discovered accidentally by people who were getting it for cosmetic reasons. My uncle is actually a plastic surgeon, and he told me I've been using Botox to treat migraines for decades. But a subsequent clinical trial was done, and it is in fact effective. Now, in my opinion, Botox is more of an art than a science. There are all kinds of different ways to inject, but a lot of the injections tend to be craniofacial injections similar to cosmetic Botox and around the scalp. Sometimes I'll give injections in the trapezius muscle or splenius capitis muscle in the neck, and if someone has bruxism or grinding of the teeth, it can also be helpful to give masseter injections here. There are potential side effects such as weakness of the local muscle. I advise not getting it directly into the eyebrow like this because it can give you those Spock eyes. There are rare bad side effects such as droopy eyelids or double vision, or even side effects due to systemic absorption of the toxin causing other things such as difficulty swallowing, although that's rare because we use relatively low doses of Botox for this indication. Now, I think I get great results with Botox, but when you actually look at the trials, it's not out of this world effective. This is a pooled analysis of randomized double-blind trials, and again, you're looking at mean change in headache days per month. And in fact, people getting Botox, the bottom line, the square, do get much better, a reduction in about 8 headache days per month. That is tremendous, but the placebo group also gets much better, and so there's really only a 2 headache day difference between placebo and treatment. I think my results are better than that, but maybe that's just my own overconfidence. Another interesting option is various devices used to treat migraine, and they can either work by nerve stimulation or transcranial magnetic stimulation. This is one example, the Cefaly device, which works by supraorbital nerve stimulation, and you can either wear it for 20 20 minutes a day for migraine prevention, or you can use it during an acute attack. This is a study for migraine prevention versus placebo. The verum is the real treatment, the sham is the placebo, and they're looking at different outcomes and the percentage change by the end of the trial. So this is the amount of acute drugs taken. So people with the real treatment are taking less medications by about 35%, about 30% fewer headache days, about 15 to 20% fewer migraine attacks, and 25% fewer migraine days, and some reduction in severity as well. These are modest differences, but it does seem to be effective. So please let me know in the comments, have you tried any of these treatments, either the lifestyle changes, the acute medications, or the prophylactics, and what kind of results have you had? And do you have any questions? I'm happy to answer in the comments below. If it's personalized, maybe talk to your own provider. I myself am lucky enough not to have migraine, though I do occasionally have migraine aura, and I have a separate video on that if you want to check it out. And let me know if you have any suggestions for future videos.